Welcome to ETMC TV and this informative presentation by Edwin Duncan, MD, vascular surgeon at ETMC Tyler. Dr. Duncan will discuss abdominal aortic aneurysms. Thank you for choosing ETMC TV.
There's all different kinds of aneurysms, and what we're discussing today is strictly the abdominal aortic aneurysm. Anything over 1.5 times greater than your normal sized aorta is called an aneurysm. And that is simply a dilation of the abdominal aorta, which is a big blood vessel coming from the heart to carry blood to all the rest of the body. The aorta is the area right above where your belly button would be, where it forks to go to both legs. The aneurysms of the abdominal aorta are typically in this location. The abdominal aneurysm is the most common aneurysm. It is the one that we repair most commonly. It's the one that we screen for. Majority of the individuals with abdominal aneurysms are 65 and older. The majority are white. The real risk factors are smokers, people with hypertension, also people with coronary disease have an increased incidence of aneurysms. Individuals that have other aneurysms in other parts of the body are at risk, but another associated risk factor is a family history. And so when we see individuals with aneurysms, typically getting the family history, it invariably turns out that someone in the family had had an aneurysm of some kind. There's no symptoms. Since aneurysms are silent, and the best term is it is like a hand grenade in your abdomen that is expanding, and at some point this will rupture. And so the way that we actually find aneurysms typically is incidental. The urologist or the back surgeons are screening a patient for back pain or a kidney stone, and the aneurysm is identified incidentally. The screening procedure, though, is an abdominal ultrasound. The abdominal ultrasound is cheaply performed. It's in every doctor's office. It is non-invasive, and you do not have the radiation risk exposure. These aneurysms, which are deadly killers if they rupture, have to be identified pre-operatively or in a condition of stability, so that we have the opportunity to study them, make decisions about the appropriate repair, and get these individuals taken care of before they have this devastating rupture. Once they're over about 5 centimeters in size, typically an abdominal aortic size is about 2 centimeters, so 5 centimeters greater, the increased risk is exponential. And that has to do with just a balloon idea again, that the more pressure on the wall, as it gets larger and larger, the wall becomes thinner. And if it becomes thin enough, then it ruptures. So an emergency aneurysm surgery is one that has ruptured. If you have what's called a contained rupture, at least you have the time to identify the diagnosis and be rushed to emergency surgery. The two typical ways we treat this today are the conventional manner, which is the old open conventional surgery, where the surgical procedure is to remove the aneurysm and replace it with a graft, a Dacron graft, which has been the standard of care for the last 40 years. We are now employing what is called endovascular stent graft aneurysm repair. Obviously, this is minimally invasive. It's done in the endovascular suite. The patient is asleep, but in terms of the involvement with the patient, it is much less. But it's necessary after someone who's had a stent graft that they have continued follow-up to make sure that the graft remains in the appropriate position, and that is done at the discretion of the surgeon. I think the patients need to be, patients again emphasize that the risk factors, elderly, white, smokers, hypertension, family history, coronary disease, those are the ones that need to be aware, and encourage their family physician that if they've not been screened, they do get an ultrasound performed as a screening procedure initially.
Dr. Edwin Duncan is a board-certified vascular surgeon at ETMC Tyler.
I went to medical school at University of Texas in Southwestern, had my internship at Parkland Hospital in Dallas. My general surgery residency was at University of Texas in San Antonio, and then my vascular fellowship was at the Vanderbilt University in Nashville. I then served on the USS Forrestal in the Navy, where I was ship surgeon on an aircraft carrier for 2 years before I came to Tyler.